you, chairpersons, and thank you, Dr. Sudipto, for inviting me for this talk. This is a difficult topic to talk about, but I will divide into the two parts of it. One is pancreatic cancer in chronic pancreatitis, how to screen for that, and second part of that is what should be the strategies to surveillance in high-risk individuals, not particularly in chronic pancreatitis. So, my outline of the topic will be risk of pancreatic cancer in chronic pancreatitis, then what are the high-risk cohort in which we should do the surveillance, pancreatic cancer surveillance, and also when, how, and who are the persons to whom we have to screen for that. So if you will look at the pancreatic cancer as a whole, in USA it is the 10th most common cause of cancer. However, if you will look at the mortality data, it is the third most common cause of death in pancreatic cancer group. What also the sad part of is that when you diagnose it, most of the time, more than 50% of the time, it is already metastasized. So a small fragment of a patient you are diagnosing in early part of the disease when it is localized, and then survival is slightly higher as compared to the overall survival when it is around the 10%, and hardly in 2 decades it has improved. This is the AIMS study. Both has cohort and case control part of that shows that of 400 patients of chronic pancreatitis, and that out of that 5 patients developed pancreatic carcinoma, and all of them will be idiopathic chronic pancreatitis. The other part of the study is case control design, in which the 1,000 patients of healthy control was taken and 250 patients of pancreatic ductal adenocarcinoma cohort was taken, and when they compared it, they found that 26 patients having idiopathic chronic pancreatitis with pancreatic ductal adenocarcinoma, and out of that 16 has a SPINK positive. And the risk factors were of pancreatic carcinoma was chronic pancreatitis, diabetes, and smoking. However, the Chinese studies has not shown that SPINK is responsible for developing more pancreatic carcinoma in this group of patients. This is another study the Samagra has done. I was part of it. Large cohort of patients, 1,500 patients, following up for retrospective design, but followed median follow-up around 4 years, and out of that 29 has pancreatic carcinoma, and out of that the idiopathic senile variety of chronic pancreatitis has significantly higher chance of developing pancreatic carcinoma as compared to the either alcohol or idiopathic juvenile variety. However, the studies has shown that alcohol is a risk factor for development of a pancreatic carcinoma. So I will end by this first part of that talk is that this is multi-society consensus on surveillance of pancreatic cancer in chronic pancreatitis. It does not justify, we don't have enough evidence to justify the surveillance in patients who are having sporadic chronic pancreatitis. Of course, the hereditary pancreatitis, because they have higher risk to develop, they require surveillance, however, not in other mutations. What is the starting is more than 40 years of age, you should start it, and when to stop when the patient is not longer suitable for undergoing surgery. Best way of surveillance either CT or MRI in background of a chronic pancreatitis, not the endoscopic ultrasound, because the view is obscured by the inflammation, fibrosis, or calcification. But what are the subset of a patients in which you can suspect the patient can have a probably pancreatic carcinoma? So if there is a long duration of a pain relief and patients develop pain, that's one condition. If a patient has obstructive jaundice, patient has marked weight loss, patient has elevated CA 19.9, pancreatic head mass on imaging, or vascular imaging. These are the criteria you should think of. If these are present, you can think of the patient can have pancreatic carcinoma in subset of patients. Now, second group, what about the high-risk individuals? Usually we don't see in our clinical practice too much, but I will go through some of the evidences. So if you will look at the type of pancreatic ductal adenocarcinoma, 80 to 90% are a sporadic one. Only 10 to 15% having mutation or familial background, having clustering. So the familial pancreatic cancers, when there is clustering of at least 2 first-degree relative, with pancreatic carcinoma, we call it familial pancreatic cancers. And out of 1/3 of these are having germline mutations, which is genetic syndromes. And how to identify that subgroups are when the pancreatic carcinoma happen in young age, multiple clustering of cases in the family, and multiple cancers in the same individuals. These are the identifiers you can identify that patient can have a germline mutations or inherited syndromes. These are the group of the patients that categorized as high-risk individuals or cohorts because they require further testing. But why do you want to screen them? The reason is that you can see that if you will take all of the pancreatic carcinoma, it is the minuscule, only 10 to 13% of the patients that comprises of. However, if you will see the lifetime cumulative risks of pancreatic carcinoma, they are very high. In some of the patients like Peutz-Jeghers syndrome or familial melanoma syndrome, it is up to 50%. So they are very high risk to develop pancreatic carcinoma. That's the reason we want to screen them. What are the imaging modality? Endoscopic ultrasound, MRI or CT scan. Obviously, each one has its own merit and demerits. But this is the study that done by the Dutch group, which blinded the US and MRI for screening purposes in these high-risk individuals of 139 asymptomatic patients. And they found the clinically relevant lesion in only 6% of the patients, and agreement between both the investigations as moderate, only 55%. And what they suggested that it's not a mutually exclusive investigations, they are complementary to each other. And what also found that US was more accurate in picking the solid lesion as compared to the MRI, and MRI is more accurate in picking the cystic lesion as compared to the US. This is the multi-center cancer pancreas screening study in USA, started in Johns Hopkins, and then we have data, collected data of around 1,700 high-risk individuals, and in that there is 26 patients has pancreatic ductal adenocarcinoma, and they have annual surveillance with either US or MRI. And what they found that if they detected ductal carcinoma on a screening, they are in lower grade and they have a better survival. And if it is out of the surveillance they have detected, they have a higher grade and they have a lower survival. So there are benefits of doing a screening in these high-risk individuals. But the question is why there is out of a screening patients develop pancreatic ductal adenocarcinoma in these patients when they develop it. So this is retrospective analysis of 16 international surveillance program, more than 2,500 patients. What was surprising or sad part of the story is that half of the high-risk individuals, those developed these lesions, have no prior lesions in previous screening, and they have developed these lesions, and out of that 10 has advanced stage, and most of them has developed before the screening period start next screening cycle. So that's the sad part of it. So we require more sensitive tool to diagnose the lesions, and still we don't know the physiology or pathophysiology. Why there are some patients is not 1 year before there is no lesion, and next year they develop the pancreatic ductal carcinoma and advanced stage. Why the late stage pancreatic cancer detected in this subgroup of patients? Again, multi-center study, collected data of 2,000 patients, but again, surprising fact was that they did not find any significant clinico-radiological differentiation points. So we don't have a identifier in which group of patients they develop late stage or advanced stage pancreatic ductal carcinoma. So we require improvement in methodology and also biomarkers to detect these lesions early, and we can treat them. There are various guidelines how to surveillance in these group of patients, but I will talk about the CAPS guidelines that published in 2019. Who we talked about those who are having germline mutation or familial pancreatic cancers. When should we surveillance? Usually at the 50 years of age or 10 years younger than when the relative is there, in which the diagnosed case of pancreatic cancer. But however, if there is a cyclin D2 kinase positive or familial melanoma syndrome or Peutz-Jeghers syndrome in this group of patients, Because they have a higher risk of developing pancreatic ductal adenocarcinoma, we should start early at the age of 40. But when should we stop it? We don't know. But usually either 70 or 75 years of age, when it is not economically benefit or patient is not surgically fit for surgery. How it should be done? At baseline, both MRI and US and blood glucose level. But during follow-up, you can alternate with MRI and US. And what should be the frequency? Although this looks like very busy, but I will just summarize to it that if there is no concerning abnormalities, annual follow-up. If there is some concerning abnormalities, either cystic lesion, solid lesion, or MPD is dilated, or there is a strictures, if there is a suspicion of malignancy or on FNA, if it is proven, then subject him for surgery. If there is a cystic lesion with some of the worrying features, do 6 monthly surveillance. If there is a solid lesion with some worrying features or of indeterminate significance, then do 3 monthly surveillance. Why are we facing this problem? Why this dilemma? Why we are not able to diagnose it? There are various reasons to that. Low prevalence of pancreatic cancers in both high-risk individuals and also in the background of patient having chronic pancreatitis. There is a limited accuracy of available screening test, as we have seen in previous slides. And also we need to better stratify the patient's group, in which group we want to screen that, so that will be higher positive predictive value to detecting the lesions. We need still to identify these group of patients. But what are the pitfalls right now of overdiagnosis and overtreatment of benign and low risk lesions? Because we don't know how they will progress, and if we will subject them to surgery, there is a higher morbidity and also mortality also. The cost is involved to them, what is the feasibility of a test which we are applying to it, and what is the acceptability for both physicians and patients. And also, of course, there is anxiety. A study has proven that in which you are screening for pancreatic cancers, they have a more anxious. We need more sensitive tool. We want to diagnose the case here, either asymptomatic PDAC or early stage cancers. We want to diagnose it. But how to do about it? Just few slides. High risk screening, we require better imaging tool to diagnose early lesion and better way to predict that. We can use the artificial intelligence, collate all the data, and then see how to stratify the patients, in which group of patients we can do better screening. And of course, liquid biopsy, I'm not going to talk about. There are a lot of data, but none of them are in clinical practice. So summarizing my talk, that pancreatic cancer is likely to emerge as a second leading cause of cancer-related mortality in USA, and that's hold true for India also. Also, we don't have a cancer registry. We have only cancer registry data also from only 40 centers that also are incomplete. It shows in recent ICMR publications. A screening or surveillance may be pursued in high-risk individual defined by either genetic or familial risk. US and MRI are recommended for this, but current evidence and knowledge does not support for surveillance and screening in the general population or in patients who are having chronic pancreatitis. But for the time being, we should rely on our clinical acumen. There is a need for urgent development of better diagnostic, whether it is imaging modality or biomarkers for early detection of pancreatic cancers. Thank you.